Good morning, everyone. I'm Scott Massey. I'm the moderator for this session. A couple of housekeeping items make you aware. You have two options to evaluate the session. Please evaluate the session. One is with the mobile app. If you have any trouble with downloading that, please go to the desk. You also can use the evaluation forms that are along the sides. If you are going to use the app, make sure you do it right after the session, otherwise it closes. Couple other things, make sure that you silence your cell phones, electronic devices prior to the session. So the session today is T103. So I'd like to introduce this session is Catch the IPE Wave, Best Practices in Interprofessional Education, New Pathways. I'm going to let the speaker intro themselves. Thank you.
Well, good morning and welcome to Catch the Wave, Best Practices in Interprofessional Education. My name is Christopher Forrest. I'm Assistant Professor of Clinical Family Medicine at Keck School of Medicine of USC.
I'm Desiree Lee. I'm Professor of Family Medicine, also at Keck School of Medicine at the University of Southern California, not the University of South Carolina. We have the same initials. Yes. And we're here together to present something that we actually started last year. So we'd like to know who was at this session last year. Okay, great. Well, don't leave because we have updates from 2014. We've done this twice more since last year. In the group, how many of you are already actively doing IPE curricula? Okay, so a good number. It looks like more than half. We look forward to hearing you share your experiences. Our experience is mostly preclinical, and we're supported by HRSA grant, so we'd love to hear about the more clinical aspects as well as how you're doing it outside of a single institutional approach.
With the IPE, I'd just like another show of hands. How many of you are actually using IPE or teaching IPE in a preclinical setting, primarily in the classroom? How many of you in a clinical setting? Okay, so it's primarily preclinical. Excellent. This is what we want to get is just as so we have an idea who our audience is. So with this, I'll have Desiree explain what our objectives and goals are for the session and how we're basically approaching this.
So we have 50 minutes. We're planning to spend about 35 to 40 going over what we've done at the University of Southern California. We're going to look over the IPE competencies and which ones we addressed in our curriculum, how we designed and implemented it and applied some principles, and what we learned from the first year that we then applied in the second year and what happened after that, and share some best practices as well as lessons learned. And in the process of doing this, we'd like you to think about design and implementation. Share with us your ideas of what you are going to do or what you've done, what pearls that you have experienced and would like to share. We did quite a thorough evaluation of our students as well as our faculty's experiences, and we'd like to hear if you had the same kind of feedback. And our final section should be a discussion. We'd love to hear from all of you. And of course, throughout the discussion, if you have any questions, please feel free to raise your hand. We'd love to hear from you. Thank you.
Now, just to set the tone here, the whole rationale for IPE in the curricula is something that's been mandated by ARC-PA for us in the physician assistant programs, but it's not limited to PA programs. Almost all the other disciplines that we're looking at either have it mandated or highly recommended, and it's becoming the case where we have other schools coming to us saying, this is a new mandate for us, what can we do with you? And so it's nice to be approached from other schools as well. The emphasis that ARC-PA has is on a team-based, basically patient-centered teams. And that's even more of a challenge because it's one thing to do that didactically, but the challenge also is to transition to a clinical situation. So one of the situations we have in place is we have an interprofessional student-run clinic. And we use that as part of the way of introducing students to interprofessional care and allowing them to be able to apply some of their didactic to it. And it gives some of the students a little experience before they go into the didactic session if they've had those, that opportunity before they actually get to some of the classes that we've been putting on. So our goal today is to share our experiences between 2013 and 2014. The prior needs assessment that we had conducted. We learned a lot by doing this. We learned what to do and what not to do. We're hoping to save you some time in implementing IPE activities by being able to give you some data on what we've done. We want to share what we've learned, but more than anything else, we'd like to have at the end some collaboration and discussion from other people as to what they found was successful, what were some of their barriers as well.
So our approach was ground up. We would like to hear how many of you have IPE centers where you work? Okay, great. Love to hear from you because most of us don't. It looks like most of the room does not have a dean or a director of an IP center or the resources available to coordinate the logistics, which is the biggest headache that we found. So we started ground up, which is from the course director level. It started with a partnership from medicine and pharmacy because we both had accreditation guidelines to meet, and medicine had an accreditation visit quite recently, and as did pharmacy, with 180 and 188 students. The following year, the PA program was invited to join. We had a grant in the HRSA program, and this was a really convenient and easy start. So we had PA students who were first and third years. We have a 33-month program, join the IPE activities. And this year, in spring, we expanded it to 6 professions. So from 2 to 3 and then 6. And the only 2 programs that had actually deans leading it that participated actively were pharmacy and dentistry. And that helped a lot. Our committee was comprised of all these professions and more. Nursing was not included as a prominent absence because our school does not have a nursing school, and we'd like to hear from the rest of you how you manage that aspect. And our committee actually gave us guidance about the competencies as well as resources. It's an unfunded committee. As we said, we are supported by HRSA grant, and we all went as a faculty team to the University of Toronto for the IPE faculty training course in June. The pre-existing course that this was built on is out of medicine, the professionalism course. And that's a 2-hour afternoon that's taught in small groups, groups of 24. We maintained that format because we had rooms. So it's really more a matter of convenience. The small group consisted of 24 students. As you can see, this is a fairly large school. We're talking about 500 students that we're putting together. So we needed 20 rooms and 40 faculty to co-facilitate these groups of 24 students.
Interesting enough, we didn't have one building that had 20 rooms available, so we were spread out through the campus in different buildings. It was a rather an unusual logistical type of challenge.
Yeah, one of the things we needed was to have escorts or guides to guide the PA students who were the guests on the medicine and pharmacy campus to the correct rooms.
Yes.
So the competencies we addressed came out of the Interprofessional Education Collaborative Expert Panel. How many of you are familiar with their competencies? Yes, so I think those are the US guidelines. There are also Canadian, Australian, and WHO competencies, which are all very similar. The only thing different out of WHO is they specifically added patient care as well as reflection as competencies, whereas the other competencies are pretty much around these. So we were rather ambitious in this 2-hour session. We decided to look at 3 competencies, and you'll see that we maybe were a little bit overstretching ourselves when we did that.
What we realized is that we needed to plan this, and it would have been nice to have a full year to plan. We ended up doing this in about 3 months. We designed a script. We designed a case and figured a case based on a typical student-run clinic, the type of environment that the students would be experiencing, underserved primary care. We recruited and trained faculty members, and we arranged for all the logistics. And there are things that you wouldn't even dream of that end up coming up when you're trying to put something like this together. And even as simple as what type of food are you going to have for break if you're going to keep them there for that long.
Yeah, one of the things we had to do was to break up the tasks. So medicine found the rooms and grouped the students, while the pharmacy ordered food and provided the guides. So at the very last minute, the communication, as you can imagine, was difficult, even with texting and walkie-talkies. It was hard to know what was happening in each of the rooms all over campus.
So once we had everything planned, the next step was we need to train facilitators. Okay? You just can't have random faculty coming in and facilitating these when they may or may not have IP experience or even any instruction as far as what the competencies are. So we provided a training for them about 4 weeks before. Those of us who went to the University of Toronto for IP training, it's a week-long intensive training. We put on some seminars for them to really teach them as much as we possibly could and give them an orientation of how to approach the students on this and what the competencies meant. We incorporated an icebreaker in there so they could have an actual feel of what the students would be going through when they had their IP experience. So the idea was we'd model to them what we were going to put on for the students. We presented the competencies, the whole concept of teams, and then we developed a video. Now, most PA programs don't have audiovisual departments that can just develop this video on the spur of the moment. Pharmacy did. And so the Department of Pharmacy, they said, oh, we'll put together the video. And I'm going to show it to you in a moment. It was absolutely phenomenal. We saw it and our jaws dropped. It was like, this is exactly what we wanted to do. And so I used snips of it to be able to show you, demonstrate to you what we did as far as the training goes.
You're going to see us as actors in there, so we are not faculty, or rather, I was a student in the video. It kind of looks weird.
And the whole idea was to have an immersion experience for the faculty so they would know what it would be like being a student in the session. And we addressed the scope of practice for each of the professions. So let's see if we can get the video to work here properly. Welcome, and thank you for volunteering to participate on this important case conference on interprofessional care. The purpose of this session is to highlight the major differences and roles that the physicians, pharmacists, and physician assistants play on the patient care team, and to identify effective communication skills, skills that can be used for collaboration and ultimately to improve patient outcomes. One of the most significant barriers to interprofessional collegiality is the lack of awareness of each other's roles and the strengths that each member brings to the table. This lack of understanding can lead to poor communication, poor efficiency, and ultimately patient outcomes may suffer. This session will primarily utilize group discussion, punctuated by small group activities and interprofessional understanding. Classrooms will consist of students from medicine, pharmacy, and physician assistant programs. Facilitators will consist of the same. This following video will demonstrate the flow of the case discussion and provide examples on how to best facilitate the small group discussion.
I'm Dr. Melissa Durham. I'm a pharmacist. I'm faculty with the School of Pharmacy and also with the PA program. My clinical practice is in pain management, and I work with people from all different disciplines, from psychology, physical therapy, occupational therapy, and the team approach is really the best way that we can possibly manage people together. So why don't you go ahead, Chris?
And next, we're going to see a short PowerPoint video that's going to discuss the value of interprofessional education and how you can better communicate with each other and realize each other's roles. In order for us to be able to appreciate what each other's roles are, what we'd ask you to do is to identify 3 facts about your profession and share those with your partner. 2 of the facts we'd ask you to share are truth points about it, and the one other point is a false statement about your profession, something that may be a common misconception.
Okay, guys, so time's up for the icebreaker. So let's bring it on back to the big group, and we're going to kind of share some of the things that you might have talked about with your partner.
All right. Next, what we're going to do is we're going to talk about a very common case. And in doing so, we want you to work as a team and to be completely open to discussion. So in doing that, you're going to have some responsibilities that you need to do. The first one is to establish ground rules.
I'm sorry, can you clarify what you mean by ground rules?
Very good question. Ground rules simply are the guidelines that you're going to use for how you're going to work together. For instance,
After you've established your ground rules and figured out who the scribe is, you're going to take about 25 minutes or so to discuss the patient case that you all have in your handout. You can have somebody read it out loud, or you can just kind of read it on your own. And what you have in your handout is a list of different things that have to be done as part of this patient's care, including like a physical exam, a medication history, patient education. So as a team, you're going to discuss who is responsible for what. All right? So you're probably going to discover things about each other's health profession that you didn't know before in determining who's going to be doing what and taking care of this patient. All right? And then after that, you'll get together and then you'll talk about what were the best practices in discussing your team roles. You know, what worked, what didn't, you know, what were some things that might have helped communication or hindered communication. And then as a larger group, we'll come back together and we'll share them.
We want to. We definitely can take on different roles, and we can support other factors than just the medication history. So,
how are things going?
well,
A little rough?
I think we have a conflict here. We're discussing roles and there's disagreement about different roles.
Okay. What's the disagreement about?
just who should be responsible for which part of the case.
Okay. Well, Do you all understand what each other's roles are? As a medical student, do you know what the physician assistant student is able to do?
Maybe not as much as I thought.
Okay. As a physician assistant, do you understand how much the pharmacy student is able to do?
Not really.
Okay. Well, maybe we should just go back and make sure that you understand each other's roles, and then go ahead and continue from there. That would be a good starting point. Okay.
Okay, cool. Great work, you guys. And then now that we've already heard from the first 3 scribes, or the first 3 groups of what the best practices are, let's go ahead and hear from the last group. Last but not least, what were your 3 best practices?
The intent of this video was to model to them exactly what the facilitators would be doing when they were actually in the sessions. Any observations from the crowd as far as what did you think there was something you could immediately put into practice in your own IP sessions?
I thought that was great in training the fellow faculty. So when I did my first IPE experience, I had no training. They would just like show up at this room at this time, and I had no idea what was going on. And the other faculty who were more experienced, which was primarily the pharmacy faculty, they sort of took over, and I just kind of felt like I was in the background because I really didn't know what was going on.
That's a great comment. We anticipated that happening.
Yes.
So not only do we have this workshop 4 weeks before, for 1 hour before the session started, between 12 and 1, we had a lunch so that the faculty who were co-facilitating met and sat with one another and discussed their role throughout the 2 hours. They allocated. So we made sure that not only were they familiar with the material, they also pre-designed how they were going to teach it. So there was some individual freedom to design the curriculum.
And as far as icebreakers goes, the 3 true and 1 false of your profession is an excellent one for teaching role recognition. It works very, very well, and we found we had a lot of success with that. The aspect of having them decide what type of roles they're going to have just in a small group got them to learn about teamwork. So here they're learning the competencies by just some simple things that they were doing together. And so what we were doing is modeling to the faculty how to teach the students. So it was a sort of a play within a play. And it worked out very, very well for us.
Yeah, and this video is actually available on MSEd portal. We submitted it. It's been published earlier this year. Melissa Durham, who was with the PA program, has now been promoted to Associate Dean in the pharmacy program. So we've lost her, but we have another pharmacist who's working in the PA program now.
Exactly. So as far as the student learning activities, you can see this is pretty much what we had talked about, what we were showing the faculty. Beginning with that icebreaker, the case based off of an interprofessional student-run clinic type of model, primary care underserved. The activity was to share the goals of what you were doing with the patient, and it worked on these 3 competencies that we identified previously.
And what we did prior to the program was to send out by Qualtrics 2 attitude surveys to look at both to prepare our students for the session, as well as to look at what their attitudes were across the 3 professions. The Ripples is a readiness for interprofessional learning scale, a scale of 1 to 5. The IEPS is the Interprofessional Education Perception Scale. It's a 1 to 6 scale with a higher score, meaning more positive attitudes. We also conducted standard student evaluations for each of the 3 professions afterwards, as well as a common Qualtrics survey. So the students had to do 2 course evaluations. We also emailed the faculty who participated for their feedback because we couldn't see what was going on in each room. Kevin Lowe-Henry, who is our program director, did go around visiting several of the rooms to see what was happening, but other than that, we did not videotape in all the 20 rooms. So their feedback was vital. What we found out, not to anybody's surprise, the most positive students were who? The first-year PA students. They were even more positive about learning than the third-year PA students, although even if you do the mean of the 2, PA students as a group were more positive toward IPE than either medicine or pharmacy students. Medicine ended up scoring kind of low. These are year 1 students. And you will see from some of the comments afterwards that they were also more resistant to being in this particular setting. We will note again that we included year 1 and 3 students, and there were separate, different perceptions from students about this course.
And that point's going to come back a little bit again later on.
1 to 5 for the Ripples, the first one, and the second one was 1 to 6, with a higher score, meaning a more positive attitude.
post-session outcomes, essentially we had a really good response rate from the PA students in particular, 94% survey response, and we were able to get quite a bit of data there. Once again, overall response rate was 82%. So we were able to come up with a number of conclusions for this. One of the questions was, in the past 3 years, have you had exposure to IPE in the healthcare setting? And physician assistant students at a rate of 46% had a yes more than medicine or pharmacy. They had more exposure. Interestingly enough, if you ask them, the next question was, have you ever been trained in a health profession other than the one you're currently trained for? 39% of the PAs said that they had been in another profession. And we believe that this is part of what leads to the idea that they had previous exposure with IPE or interprofessional care. Which profession did you learn the most about during the session? This really doesn't surprise us. Medicine pharmacy students learned most about PAs. We kind of expected that. And the PA students learned more about pharmacy. Also, no surprise, PAs know very well what physicians do. I think most people know what physicians do, but a lot of times we underestimate what our fellow pharmacists can do. So as a result of this IPE session, you can take a look at the blue shows that increased knowledge. Pretty much they all experience increased knowledge. There's no significant difference between there. The red shows a reverse score saying, I'm more confused. The way the scale works is none of them were really more confused. They were either neutral or didn't feel confused at all about it. But it really confirmed that we met our objective of teaching them about the roles of the profession, about teamwork and communication. So post-session feedback, this was painful at times. We didn't anticipate that the third-year students, PA students, would have this clinical experience with a diabetic case that the preclinicals didn't. And it didn't matter that the preclinicals were PAs or MD students. It made the third-year PA students feel like, well, they knew so much, and that really worked against the whole aspect of teamwork. It caused the stratification of experience between them. So there was some competition that came out. The case was also too complex. We were trying to give them a really good diabetic case, and so the focus became more on what the treatment is and how do you diagnose this, and not on the teamwork and the communication aspect. So that was something we learned about, and that, once again, that led to some more competition there. And because of the competition, the scope of practice became unclear. PAs, oh, we can do this, we can do that. And medicine's saying, well, what do you mean you can do this thing? We can, and it caused some tension in the groups. So we learned not to mix students at different levels. Among the faculty, just coordinating 20 rooms was a logistical, I wouldn't say nightmare, it wasn't quite that, but it was difficult. And something we didn't anticipate to be quite as complex as it was. But the training and the script that we had offered a structure that was extremely helpful and helped hold things together, and that's probably what made it more of a success than anything else.
In terms of the AV, we learned from that by announcing ahead of time for everyone to bring their iPads and their computers so that if the AV failed, we can go to our own and have the groups of 6 students watch these videos on their own iPad. So we sent out the link to these videos ahead of time.
Yeah, and the AV did fail in a number of the rooms, so yes. It was well anticipated. Strengths, the whole idea that we provided faculty development was a strength of our process. The ability to offer the students face-to-face interaction was a great way to teach IPE. We included reflection. We thought that was a strength as well. When you take the time to reflect what you've learned, it activates this metacognition among the students where they're really more able to learn and observe what where they are at, where they've been. And then the comprehensive assessment that said at the end gave us the data, the statistics that we needed to work with.
And a comment about the face-to-face activity is that there was at the same time a parallel IPE curriculum that was being designed for clinical students to work together on the electronic health records. The difference with that curriculum was that it was all going to be virtual. So all the different professions were going to get into records of 2 or 3 patients and work around that patient remotely off-site. And then they were going to be debriefed separately, medicine, pharmacy, PA, OT, PT. And as you can guess, that kind of fell through. And it was interesting, it fell through for many reasons. Not only because the committee itself that designed it couldn't meet face-to-face, but also because they couldn't design even a week in which all the students could jump in and take care of these virtual patients. So these things are not easy. Even a virtual IPE course is not easy to design.
No, it's not.
Yes.
And the whole aspect of having comprehensive assessments, we were anticipating that we would be repeating this process again next year. So having an assessment would allow us to be able to improve on some of the errors that we made and some of the mistakes. And so the next, and Desiree's going to go into that very shortly, we'll tell you how that worked as well. As far as barriers, just coordinating all the rooms was a huge barrier. The logistics, the video didn't work in some of the rooms like we mentioned, so we had tried to arrange for backups, but it made it so it wasn't, there wasn't this parity in all the rooms as we would have liked. Conflict among the different stage learners, we talked about that. But an unanticipated issue was when you have an interprofessional team of faculty and some faculty are trained in a traditional approach where the physician is the team leader and there are no other options, it leads to a certain amount of stress. And so we learned that how to deal with that conflict and how to try to be as inclusive as possible for people with different backgrounds.
So how did you resolve that? Because that's a situation that we're in now. Each discipline is not specifically medicine versus PA versus PA or PT, but within PA, OT, PT, nursing, and ourselves. So how did you resolve that? Everybody had their own opinion. We need to do it this way.
Yes, thank you for that question. So the question is that all the different disciplines and programs have their own opinions about their own roles within a team. So when they start teaching students, how do you train them to have the same voice? I would say we tried to anticipate that in the faculty training. We allowed voices to be heard, and we certainly heard a lot of dissent. Why are we even teaching this? We also gave permission to faculty not to participate if they really felt they didn't agree with the principles of this. And so I think by doing that and listening and offering alternate ways of presenting themselves during the small group, that by saying, this is not how I do it in practice, but I can see that in primary care. So they can say that in my particular discipline, we need to be more proactive. The team leader is the physician in the emergency room or in the surgical setting, but I can see that in the primary care setting and patient-centered medical homes, that this team approach might work better. So we can persuade everyone that in many clinical situations, the team approach works. We find that this can go across. And having the two co-facilitators meet beforehand and be friendly and learn about one another also helps that socialization aspect.
Yeah. Our goal wasn't to persuade as much as it was to learn to appreciate each other's roles and recognize where the limits are for each of the different roles. So what we did the following year to try to help exactly that situation is we developed among the different professions a 1 or 2 page summary of what all the roles are for their profession so that all the faculty could be completely familiar with that before it went on to the students. And that may have helped that some too. To go on here, best practices learned. Although we were able to accomplish this in 3 months, please try to allow a year. We'd really recommend that. It does take a lot of time. Pay attention to all the logistics. Try to involve the same level students. So if they're all preclinical, that's to your benefit. You need to prepare the faculty ahead of time. So as much faculty training as you can do. Once again, we did that 1 month ahead of time, the training with the faculty, and then we had just immediately before it a 1 hour refresher just to make sure that they were all on the same page and they remembered what we had discussed the month before. Food in a social environment adds to bonding. It really makes a huge difference as to how people do. And then reflection, once again, was important. So with this, I'm going to have Desiree focus on the 2014.
Okay, so what did we do this year that was different and what impact did it have? We took the same course, same hours, same kind of grouping, and we reduced it down to 2 competencies, roles and teamwork. We took the clinical case out because there were so many conflicts around that, and you could hear what happened when we did that. And in April, we expanded it to 6 professions, a lot more ambitious. Now we have 800 students instead of 500. We took out the third-year students and we focused on the preclinical, and most of it was socialization. We showed a video that was out of University of Toronto that showed conflict within a team to talk about how to use role clarification in order to have a team work better, and focus on those 2 competencies of teamwork and role clarification. And this is the mix Now we have 54 physician assistants, so each of the rooms would have had fewer physician assistant students than the others, which were bigger groupings. Medicine, pharmacy, and dentistry took the largest in terms of numbers. And dentistry had to come over, so we were host to dentistry. We used the same icebreaker. We had another icebreaker that also talks about the reasons you came into your health profession, so that all the students found they were very common reasons, and no matter what they went into, and that was a nice bonding exercise. The teamwork video was meant for them to critique what are good practices, what are not so effective practices, and then we also had reflection associated with that. As for faculty development, we also had faculty development for the additional 40 faculty we needed for this session ahead of time, a month ahead of time, and we repeated the 1 hour because that was so effective for faculty to meet one another and plan it out.
I'd like to emphasize that the video that we did for the teamwork is different than the one we just showed you. We used some videos that were developed by the University of Toronto, and they are available online or for
purchase. They're $99.
For purchase, yes.
The only proviso is that they are in a Canadian setting, so they will use different terminology within the videos.
Yes.
So in the post-session outcome, so this time we didn't do the ripples and the IEPS because we didn't feel like we needed to. Out of the physician assistant responses, we got 63% because the Qualtrics survey by mistake did not get re-administered on the second and third go. Overall, we had a 2/3 response rate to the post-session surveys. By physician assistants only, we found a much more dilute response. So here we are talking about the scale strongly agree being on a 1, strongly disagree being on a 5. So the PA students this time around, who were only first years, really didn't learn that much more about all these professions. So this is about 8 months after they started PA school. Next. And as to individual questions about them having assumptions about other professions, being able to correct their misperceptions and reflecting on their future role, again, they didn't reflect as much learning as they did the year before. If you recall, the scores before were between 2 and 3. Now they're between 3 and 4 out of a scale of 5. And the other questions, next, was about promoting interprofessional learning, again, in the range of 3 to 4. So even though we've tried to improve and change the setting as well as remove the case, what we found was that the PA students didn't actually say that they learned as much. However, in their comments, which we're going to look at, in terms of what they learned, all the professions, not only the PA student comments, and we have a ton of them, all the students make comments, that the most important thing was about the face-to-face interaction, the sitting together and chatting, the social part of it, the icebreaker part about other professions learning that they're the same as themselves and their scope of practice. As to improving the session, see what they said. Now they want a case.
We took the case out, so now they want it.
Yes, how many of you have that experience in your curriculum? You do one thing, they complain, and then they say, do that thing back, because each group of students didn't have the experience of the year before. So they said a case would have really helped them gel as teams. And then all of them positively said we want more. So even though they were a little dilute about what they learned, they said we would like more exposure, and in particular, more clinical exposure. And again, our best practices from having done this the second time now with 6 professions is to, again, just plan well ahead. This time we planned 6 months instead of 3 months ahead. Logistics continue to be a challenge, although they get better and better each year. Each year that we have the same group of people work together, we found fewer and fewer logistics, including the AV logistics. The same preparation and providing food was helpful, and earlier perhaps would be better. So we're thinking that maybe for this preclinical curriculum, the first 3 months of school would be an even better time to do it as opposed to waiting to the end of the first year. Okay. And to update you further, this session was repeated in September. So we brought it forward from the spring to the fall for this year's students. Unfortunately, we were not able to have PA students join because they didn't have curricular time available. So they're going to do it in the spring, the first year PA students. This time we added nursing and social work, and we changed the video based on that, and this time it really went very, very smoothly. We're just getting evaluations on this group of students who are all preclinical very early, using a better set of video, which is on YouTube. It was available to everyone talking about teamwork. So I think we finally get it right.
But Desiree, I think you brought up a good point. That's one of the hugest challenges is how do you coordinate a class together with other professions? your curriculum design is completely different. Trying to find common time sometimes for one class is impossible. For one 1-hour session is not impossible, but it's very, very difficult. And try to combine that with 2 or 3 professions. I think this was an awesome task to try to accomplish, and once a year is about as much as we could handle for that.
Yes, yes. And you know, in terms of expanding from 3 to 6 or 7, I thought it would be like 3 times harder. But it's like asking a mom, gee, how do you manage 6 kids? She says, oh, once you've got 3, it doesn't matter, they're all, you know. So it's like when you've got the logistics for 500, the logistics for 800 isn't that much worse. We split the campus for 800 students, you know, 2 campuses, dentistry and medicine and pharmacy, and it still worked okay.
So at this point, we'd just like to open this up and find out what you're doing as far as IPE, or if you actually, let's do questions first, and then we'll open it up. Yes.
I was fascinated. Did you see the dynamic of the discussion change with social workers, number 1, and number 2, have you thought about adding other mental health workers?
Adding
Other mental health workers.
Oh.
Like mental health, like psychologists.
Great question. So the question was, did the social workers' presence change the dynamics, and are we going to have clinical psychology join? So the answer to that is that we would love to have as many professions as we can, but it's limited by our access to those schools. Our social work program is very different. They branch out really early. The minute they start, they've already budded into geriatrics, pediatrics, social work. So we were able to only get like 40 social work students this time. So in each group, there were only 1 or 2. They weren't heard as well. One of the feedback was make sure that the faculty ensure that the social work student speaks up. We don't have a clinical psychology school, so we would have to reach out to a school outside of USC, which we did for nursing. We reached out to a nursing school outside, and it worked. They were very enthusiastic. So we hope that we'll be able to add that. So I can't really answer your question. We'd love to do that, one step at a time.
Did you notice that the social workers were, one of the things I'm fascinated about is the lack of communication and the ability to communicate between professions and with the patient.
Yes.
And I think social workers have a key to that. Were y'all able to see that?
Yes, the psychosocial aspect of medicine, yes, that did stand out. At least in the group that I facilitated, I had 1 social work student. And we weren't able to have her voice heard as much, but within her little small group of 6, the students around her were able to say, this is what the social work student brought out that we didn't notice. So having more of them would be wonderful. Thank you for that question.
You talked about the complexities of the diabetes case in terms of the students' understanding of the case itself. Was in terms of designing that case, was that a collaborative effort across the different disciplines that you had?
The question to the group is, in developing the diabetes case, was that a collaborative effort as far as the complexity of the case and how it was drawn? And yes, it was. It was an interprofessional team of faculty that actually put together and designed this event and went through the case and edited it, went back and forth numerous times.
For the whole 3 months.
And one person would say, "Oh no, this is way too complicated." Send out. Well, no, this is no challenge, and it should have something with the glucose level in it, and it went back and forth.
Yes, and the pharmacy had a great input about, do you want the brand name in there, or do you want the generic names and the dosages? Will the PA student first years know anything about that? And so that's how it ended up being more complex, with the pharmacy saying, oh, right, we need to have so much detail in this.
I was thinking in terms of adding all the professions or all the disciplines in your IPE initiatives, how much more complex would that process be to design cases?
Well, part of the reason why we chose diabetes is because that seems to be common where physical therapy, occupational therapy, pharmacy, medicine, the social work, all of them could, nursing could all basically take a part in a perspective and something that they can contribute to the case. So that was the reason for that. We also examined the idea of a stroke as an option. We had a few other options. And so all these things were thrown out as far as ideas goes, and we just settled for diabetes. It was the simplest, we thought the simplest, most straightforward, and even then it was complex.
Yeah. Actually, there is a resource we use subsequently called the University of the McMaster Ottawa Team OSCE website has got 10 cases that are amenable to IPE, and each of the cases had different professions involved, so you get some inspiration from going in there. It's open to the public, and you could adapt one of the cases to use as well. Thank you for that question.
But
It's the McMaster Ottawa Team Objective Structured Clinical Exam. You could Google that and get onto their website. They have a scale also for rating team behaviors. And as an aside, we had a suggestion which we may implement in future, a great suggestion from a faculty about role clarification. They said, ask the students to imagine that a patient walks into a conference by mistake, someone who's diabetic or who's had some chronic illness, and walks to the tables where you are representing social work, you are representing medicine, you're representing PAs, and the patient goes up to you and says, what do I do about this? What would you say to that patient about your role for that condition? So for a preclinical student, that might be easier than actually solving a complex case and coming up with an assessment and plan.
Okay, question?
My question actually goes right to that. We found that working with our preclinical students, they didn't know their role enough to explain it to the other professions.
Yes.
I would be interested.
Yeah, and for the sake of the recording, and other people might not be able to hear, I'm going to repeat these things. For the preclinical students, often they themselves don't even know what their profession's role is or the full scope is. And so, yes, that was part of the process is them learning about their own profession at the same time.
Yes, and we did send out a document which has become larger and larger because we added social work, nursing, and clinical psychology was in there, public health, and now it's 25 pages long. We emailed that ahead of time, which of course half the students wouldn't read. So that would be a perfect platform to say, well, you know, when you go back after this session, go ahead and read not only about the other professions, but about your own profession's scope of practice.
Right.
And it gives all the websites for every profession for them to update the scope of practice.
Right, and that paper went actually to the deans for the dean's approval and went through a lot of different stages to make sure we were accurately portraying each of the professions. So that was a huge accomplishment there.
Any experiences with doing this in the clinical area? I should think it would have the huge impact having all the different students around the patient, your patient. We don't separate preclinical and clinical stuff. If we haven't had it, but if we were doing it, we could start.
The question is, any thought of doing that during the clinical year rather than just preclinical? Are basically clinical experiences, we have a couple of them. We have a geriatric volunteer curriculum for the students where they can have an interprofessional experience on a geriatric site. We also have a student-run clinic that works in an underserved area of primary care, downtown Skid Row area. And both of those are clinical experiences offered to both preclinical and clinical students to go and learn from. But as far as actual curriculum itself, we don't really have anything designed for that.
Our challenge is numbers. When you add them up, we have 800 students. How do we get them in all the clinical settings? So we've had to provide a number of volunteer experiences by, and then have the students all rotate through. Generally with the PA program, almost the entire class by the end of the second year has that experience, correct? Chris is one of the co-directors of that.
Right, I'm highly involved with the student-run clinic. One of the reasons why you saw the diluted results with the PAs during the second year was we had a lot more involvement in the student-run clinic. So by the time they did this in March, the preclinical students that were in October starting to go to the student-run clinic and doing blood pressures and seeing learning about the different professions, by the time it came to March, a lot of them had already had this experience, and I think that influenced a lot of the figures that you're looking at during the second year.
So actually we could hear there's other programs here. I heard MD Anderson, you have actually postgraduate students that you like to expose to IPE, and you have a lot more clinical exposure, Mara and Laurie, right? What are you thinking of in terms of clinical experiences?
Well, I'm just starting to explore this. The literature search that I've done, I've found very little at the post-professional level. And so it's something that at our academic center, we're doing mainly postgraduate education. And so we're exploring what kind of things could we do for our PA fellows, our medical surgical fellows, physician fellows, our we are pharmacists and clinical pharmacists that are fellowship programs relating to IPO. And I haven't really been able to find much of anything in the literature about that. Everything is more at the kind of classroom level, or most of it is.
Right. What we found
The comment was, just so we can repeat this, is that through a literature search, you couldn't find anything on a postgraduate level as far as interprofessional education, particularly for PAs, but probably across the board. One of the things that we've done is when we came back from the university training at the University of Toronto, is we put a collaborative together among the different professions, and we basically did faculty development and invited faculty from all the different areas and extended it to other people that were actually out there in practice as well that were free to come. We had library science show up. We had all these people from an extended idea concept that we even would have thought of to begin with, and it worked very, very well. And people got excited, and they brought it to their group, and they started doing more IPE. So that's one thing that can be done.
So getting champions and starting with a committee maybe to design it. And there are a lot of simulations out there, simulations for surgical situations, for medication reconciliation, as well as prevention of medical errors that are interprofessional team activities that if you can bring everybody physically into a room for 3 or 4 hours, you can do those simulations as well. Yes.
I'm from UNT in North Texas, and our campus is doing very similar things to yours with different, in fact, we are integrating with other campuses. TCU's nursing school is coming over to our medical school with PAs and all that. We've learned, one of the lessons we've learned similar to yours, one of those is that you can get too many different fields in one room too as well. And the other thing, as one of the people who participate in this, and I'm curious if you've learned any of this, but my sense is that we're not spending time with our facilitators, fully engaging them in what the goals and purpose of this is. Have you noticed a similar thing?
That's the entire purpose why we've been trying to do these facilitator trainings, and that's been a struggle. And trying to get them involved in dealing with different perspectives and different experiences, it's not an easy thing to do. What we would like to do is have people that are legitimately interested in IPE as faculty participate. That would be our goal, rather than saying we want any faculty that's from any school involved.
In observing some of ours, I've noted that there's a tendency to want to teach the groups rather than facilitate the groups. And it's also our experiences, those of us who've been at this for several years, we're not typically engaged in sharing interprofessional training, in practicing in that way. So we're learning it as we're going along as well as facilitators, but certain facilitator skills, I think, are helpful whenever you're going to try to.
Thank you for that comment. We have 2 minutes, so we'll, I think, quickly comment on that, which is that if you put an experienced facilitator with a less experienced one, hopefully the less experienced one will learn from that and have them talk to one another at the end. And in our group, I had a dentistry faculty who did stand up and lecture every time, and when he did that, I kind of gently brought it back and saying, oh, and what do you all think? And change it into more facilitatory. And he actually said, oh, gee, I haven't taught like that before afterwards. And so I think we can actually learn from one another.
Yeah. Desiree, I think I saw about 3 other hands here. I'd like to just do a rapid fire, make sure we've included as many people as possible.
Sure.
So very brief answers from both of us. There was a question over here.
I had a question as far as knowing the roles. We're trying to do this with some OD students and pharmacy, and coming from feedback from OD and pharmacy, they want to do it with first-year PAs, but third-year OD and pharmacy, they feel that OD and pharmacy don't know their role quite at the first year. Have you considered doing a later year with the OD and pharmacy and an earlier time with the PA?
No, it's a simple answer. I would say that's a committee decision based on your local IPE educational objectives. So I think that would be a local decision. In our case, we kind of just stuck with everybody being beginning learners. It depends on the case and the curriculum.
Like I say, clinically in the student-run clinic, we will often pair a different year just because their experience level in IPE and with clinically is about the same area. So sometimes we will combine them. In this exercise, we did not find that beneficial. Other questions? Okay, well, thank you very much. It was a pleasure. Thank you.
Thank you.
If you would please fill out one of the forms. We're going to put one slide up here. This has our contact information. If you'd like to email us for copies of the slides, any information, feel free to contact us.
Thank you for your participation.
Everyone, if you could please either evaluate with your app or fill out the yellow forms and leave them along the column so I can pick them up. Thank you very much. This is session T103.